let's go back to the physician panel report and how to use it for quality improvement. So Sandy, I have a question for you. Do you ever run into barriers engaging physicians and teams in quality improvement?
No, never, Sue. Just kidding. We know that physicians are very busy and they always have competing priorities. But having this report is an opportunity and an opportunity to suggest to them that they get their report, and I'll help them interpret it for them. So I'll dig in, do the legwork, find the areas of opportunity, and also look for some of those areas where they're doing a really good job, because they like to hear that as well. Once I get the report, one of the first things I look at is the size of their panel. And if you can see on this report, it looks like this physician has almost 2,800 patients. Yikes. Pretty large panel number when we consider a typical panel to be up to about 1,500 patients for a full-time physician, whatever full-time means for a physician.
Yeah, and so the next thing under the practice characteristics is really looking at that physician's supply of visits. And so this is showing the total visits to this physician, and that this physician in the last year of data was able to provide 9,708 visits. The other thing that I wanted to draw your attention to is the visits by non-panel patients. And so what this is telling us is that this physician actually provided 996 visits to patients that did not belong to this physician. So they were other physicians paneled patients. So now we have the supply of visits that the physician can provide, but what about the demand of the panel? And we're going to want to look at the demand in the utilization section of the report to find this. So we're flipping to utilization, and what this is, utilization is talking about this entire panel. So it's not just visits to this particular physician, but it's visits to all physicians. And so what we can see here at the bottom is that this panel of patients actually had 10,834 visits in the same year of data. So this is the demand of the panel of patients. And if we look at the balance of supply and demand, in this example, the supply that the physician was able to provide was 9,708, but the demand of the panel was 10,834. And so when we look at this, we can see that there was a shortage of visits of 1,126 for this panel. So if the physician is not able to provide those visits, these patients have to go somewhere else to seek care. So Sandy, if you had a physician in this situation, and we've run across a few of them that are in exactly this situation, what else might you consider?
Yeah, good question, Sue. So I think the next thing I would look at would be their third next available appointment and see if it's getting longer, or is it getting harder to get in to see this physician. And in this case, it appears that it is getting longer, that the TNA is increasing. That would be another red flag to me, indicating that maybe their panel is too large or that their supply and demand don't match in some way. The other thing I look at is the age distribution of the panel. So, for example, in this example, the panel doesn't look to be a lot older than the average for the PCN or the zone. But in some cases, if the patient panel looks older, this could be an indication that they're over-paneled, that maybe they can't handle that many patients. I also look at the burden of illness. So in some cases, the panel might be a lot sicker than the average for the PCN or the zone. And I've actually recently had that happen. I had a physician call me to say, I need to find out what my ideal panel size was, and we're going to go into that in a little bit. So I tried to help him look up that information. And when I went back to him and said, he's a young physician that just started in the PCN, but he took over an older physician's panel. And the patients were older and sicker. And his experience, he said to me when I told him that, was that's what he felt like every day, is that's what he was seeing with older and sicker patients. So this was kind of a relief to him to know that this in fact was the case, and that maybe he couldn't handle a panel size as big as he thought he could.
Perfect. Thanks, Sandy. So what else might you consider in the HQCA report?
Continuity, of course, is a big deal, and what we see in this report is 31.5% of this physician's patients see this physician 80 to 100% of the time. So this is less than the PCN in the zone. They also have 68 of their patients with low to moderate continuity. We know from all the research and all the things that we've been doing for medical home in the last bit, we know that the best thing patients can do for their health is to have a family physician and see that family physician on a regular basis. Patients are being seen somewhere. Where are they going? So a great area to look at in the report is those potentially avoidable emergency room visits. This tells you what percentage of your patients are going to the emergency room during office hours for GP-sensitive conditions that would be better managed in a medical home. The new report this year, the times of the visits are separated into office hours, which are Monday to Friday, 7 to 5, after hours, which is Monday to Friday, 5 to 9, and weekends, 7 to 5, and other hours, which is overnight, weekend, evenings, and stat holidays.
So now we can see that the size of the panel is affecting the results in many areas of this physician's report. And so there's an opportunity for improvement clearly. So Sandy, how might you help a team implement some quality improvement?
Yeah, I think it's really important just pointing out these measures to them so that they're aware that something's amiss in their report, and being able to kind of zero in on each one of those measures that show them that something's not right. And in this case, it seems that this physician and team maybe need to do a little bit more panel identification and panel maintenance work. I also use a simple panel equation tool to calculate their ideal panel size.
Yeah, so let's look into the balanced panel calculator. Now, for those of you who have been through access improvement measures and really dived into it, there are some very, very complicated calculators that you can use, but we're going to share a really, really simple one. And you can find this. We made it available through the innovation hubs that we were working with on PACT. Patients collaborating with teams. And so if you go to the Toward Optimized Practice website, select PACT and then Tools and Resources, and scroll down to test box number 4, and there you will find the balanced panel calculator. And this is what it is. It's a very simple Excel spreadsheet that is very, very easy to use. So on this calculator, you're going to look at the number of appointments per day that the physician is able to provide, the number of days a week the physician is in clinic, the weeks per year that the physician is working, minus the stat holidays, and then we're going to look at the return visit rate for this panel to calculate the panel, the ideal panel size. So where do we find that return visit rate? So in the report, under the panel characteristics, you will find something that will be called return visit rate, but that's not the one we want to look at when we're using the calculator. You're going to want to go back to the utilization section of the report and look at the visits to any family physician, because we want to understand what is the return visit rate of this entire panel. And this is where you're going to find it, is the average visits per patient. This is what we're going to plug into our balanced panel calculator. So if we were to say that this physician is providing 32 appointments a day, 5 days a week, for 46 weeks per year, minus the 12 stat holidays, with a revisit rate of 3.9, the ideal panel size for this physician supply would be 1,884. But if you remember in the report, it said that this patient or this physician had 2,792 patients paneled to him, and therefore we have a mismatch. And so this patient is overpaneled by about 908 patients. So, so Sandy, clearly this physician is overpaneled. What recommendations might you make to this team?
Yeah, so from a QI standpoint, let's try and get them to start thinking of some of their own strategies. First off, can we convince them to close their panel? Because they obviously have enough patients on there and they're not able to see them, and some of their patients are going elsewhere. Let's ensure that they're seeing their own paneled patients. We know from the report that this physician provided 996 visits to patients that were not paneled. Maybe a little bit more panel identification is in order. We could look at better utilization of the team members. Is the physician doing work that could be done by another team member? Also, let's look at distribution across other providers in the clinic. And I just recently had this happen. Is there a newer physician in the clinic that is underpaneled? And should this physician be taking some of these patients before opening the practice to new patients in the community? So looking after their own patients first. It would be a really good idea to look at their screening and how being overpaneled is impacting their screening rate. This might help them to be more in favor of trying some of these strategies.
Yeah, so let's look at some of these, this physician's screening rates. And so here's the breast cancer screening rate, and you can see this physician's panel screening rate is quite a bit lower than what we're seeing with the PCN as well as the zone. And then looking at the lipids results, it seems to be doing a little bit better than the PCN, but is still quite a bit lower than the zone. And as Jody mentioned, the report now lets you look at those higher risk populations for some of the screening. For example, patients with hypertension for lipid screening. So this is showing those patients with hypertension and whether or not they've had the screening for lipids. And once you click on these numbers again, down at the bottom for not screened, again, it will show you if you have a confirmed panel, the PHN, so you can find these patients, and that's something that you may have your medical office assistant or your team to help get those patient screening taken care of. And this ability to, especially if we have a large funnel of patients that need to be screened, it helps us to focus our energy on where we'll have the biggest impact. So focus our quality improvement activities on those patients that will benefit the most given their other chronic conditions. So I'm going to talk about length of stay. So this is one of the new measures that is now in this year's report, and that is looking at the ALOS, which is the actual length of stay in hospital to the ELOS, which is the expected length of stay. And it's a ratio. So where the expected length of stay information comes from is from CIHI data. So it's looking at across Canada, looking at certain conditions and procedures and why patients would be in hospital. And for that condition and those procedures, what would be the expected length of stay on average. And so what this is doing is comparing the actual length of stay to the average expected length of stay. I know it's very confusing, so it's a ratio. So in this panel, we would see for the 0.99 that this physician's patients have an actual length of stay that is very close to the Canadian average for ELOS. And you can see that the panel for the PCN actually is 5% worse than the Canadian average, and so is the zone. It's 5% worse than the Canadian average. So that's what the ratio is telling us. So now, if we look at those patients that have high continuity, so we know that those patients that have high continuity to a provider typically have shorter lengths of stay. And that's exactly what this is showing, is that the actual length of stay is much better than the Canadian average for this particular physician's panel. And then if we look at the ALOS-ELOS ratio for those patients who have low continuity, wow, look at that ALOS-ELOS ratio. These patients are staying in hospital a lot longer than the typical Canadian average for those conditions and types of procedures. So because this is where patients who are in hospital have no one really to catch them in the community, to help look after them, and being able to get them out of hospital sooner to their home community. So this is really interesting data.
Wow, that really is informative about how continuity affects the length of stay. Is there anything else, Sue, in the report that would help us as improvement facilitators to really drive home the impact that continuity has?
Yeah, for sure. This is another new measure, which is the readmission to hospital. And these are people that, and you can change your readmission period. So these people have been in hospital and then they have been discharged. And this is looking at those who get readmitted back to hospital within 30 days of their discharge. And this allows us to, you can see that the number of discharges was 15, the number of readmissions was 3. And also on the left-hand side, you can choose, gender different conditions that the patient has. But if we look at low continuity, again, you can see that impact of not having that relationship with the primary provider on readmission to hospital. So Sandy, now that we've looked at various parts of the report, what kind of questions or comments have you heard from teams?
They've been pretty open, and I've really enjoyed digging into this data for them. But this is one of the questions we get is they don't trust the data. So when I hear that, one of my responses is, all right, if we're using a proxy panel, let's get a confirmed patient list. That way it's based on the patients that you consider to be your panel. And this last report we actually got every physician in Leduc, Beaumont, Devon to submit a panel list and get their confirmed panel back. I think the other thing they need to understand is that the report includes more information than they can get from their EMR. So it includes data about patients that seek care elsewhere. And also, they're getting just a snapshot in their EMR, and this represents the whole healthcare system and the organizations that work with primary care. I don't think also that physicians sometimes understand that the data follows the patient. Maybe they didn't provide the care for them, but they may have received it elsewhere. The higher the continuity, the better representation that is. Yeah, this is pretty typical not to have time, and I really like digging into the data and letting them know that I'm happy to review the data for them. Ask them if there's any specific areas they think they might be interested in focusing on, and as Sue mentioned, and I think Anila did before, you know, get on there and use that delegate button to find out what areas they might be doing well in and what areas of there are for opportunities for improvement. What does the delegate form, as Neela had showed that to you earlier, and it's found on that delegate access, just so you're able to get a hold of that. I think it's really important as improvement facilitators that we're able to get those reports. I think one of the other fears that I often have is what if the physician asks me what a measurement means and I'm not really sure. And so I think, again, it's an opportunity to look at the report yourself and know that you don't have to have all the answers. This report, actually, I'm not a numbers person, and this report I've been able to flip through it the last little while, and each section has this explanation about the measure on the right-hand side of the page. As Jody mentioned, you get to that data dictionary, it'll take you to the exact page. When you press on the question mark, it's going to take you right to that data dictionary. So it really helps me to be more informative when I'm going into the clinic, but also I don't have to have all the answers. And I think one of my most valuable answers I have as an improvement facilitator is, I don't know. I don't have the answer, but I do know that I can go and get some help. So don't hesitate to contact HQCA, and remember your AMA team members are here to help you as well. How do I sell the report? So I had to sell the report to myself a little bit first. When I was working as an improvement advisor with TOP and doing the improvement facilitator training, I kind of glazed over when it came to the HQCA report, and I kind of let Sue take on the reins, and she loved this stuff, and I thought, oh, I'm just going to leave this up to her. So really being able to dig into that report and start piquing a little bit of interest in what they might want to improve on. So my plan for this next report that's coming, and talking about it today was actually the topic of a meeting I had earlier today, is to take, first of all, the PCN level HQCA report, share it with the board, and help them to decide what their direction might be. But in order to connect with some of the physicians, I'm going to pull out the top 3 things that each physician is doing well, and the bottom 3 things that might be areas of opportunity for improvement. And I'm going to share those with them and offer my help to come out and do a quality improvement project around that. One of the things that stood out for me today in the report that I never thought of, and thank you, Jody, you pointed this out, but was the panel report tools and the possibility for them to earn some CME credits for reviewing those panel reports. I think that's going to be really helpful for me to go out and help sell this report again.